So today we are going to talk about the module cardiology in this ERPM medicine prep, and I'm Dr. Ishfaq. I'm a registrar of medicine, and for today, uh, these are the topics which we are going to deal with, starting from the anatomy and physiology, and going to the peripheral vascular diseases. So today we are going to discuss on the anatomy and physiology of the heart. So this here is the diagram. If I can annotate, this here, this is the right coronary artery, and this is the left main coronary artery, and they all, both of them, origin from the level of the aortic cusp, just above the aortic cusp. Now, the thing is, what we need to understand is that both of these arteries get wound around the heart, and somehow they form collaterals which anastomose with each other. So you have the right coronary artery, and this right coronary artery ends up with a posterior descending artery which goes down the posterior interventricular groove downwards to the apex. And from the other side, you have the left main coronary artery, which divides into a left anterior descending and a left circumflex. Now, the left anterior descending comes forward and it goes through the anterior interventricular groove, and it goes downwards to the apex. And you see that there is an anastomosis between the left anterior descending and the posterior descending artery. When you talk about the left circumflex gets wound around the heart through the lateral surface in between the atrioventricular groove, and it gets proceeded backwards, and then it tries to anastomose with the right coronary artery, and it supplies the left lateral part of the left ventricle. So what we need to highlight is that the right main coronary artery supplies the right atrium and the right ventricle. It continues as the posterior descending artery, supplying the posterior part of the interventricular septum and the posterior part of the left ventricle. Now, the left main coronary artery divides into the left anterior descending and the left circumflex, and it supplies the anterior interventricular septum and the anterior left ventricle. Now, the left circumflex, like I said, it travels along the atrioventricular groove and supplies the lateral part of the heart with its marginal branches. And what you need to remember for your exam is this point. So the SA node and the AV node are both majorly supplied by the right coronary artery. Now here, there is something called the nodal branch. These nodal branches supply to the SA node. So 60% of the time, this nodal branch arises from the right coronary artery. And as far as the AV node is concerned, 90% of the time, right? 90% of the time, the AV node is supplied by the right coronary artery. And we should know that right coronary artery lesions. Now, right coronary artery supplies the right side of the heart and the lower side of the heart. So the inferior MI can almost always be associated with a heart block and bradycardia. So we need to look out for those complications. So when you talk about the main functions of myocardial cells, now you have a contractile function, and you have an automaticity and impulse conduction. Okay, so there are cells which conduct impulses, and there are cells which receive the impulses and contract. So now we talk about the SA node. Now the SA node is a spindle-shaped structure located lateral and the epicardial aspect of the junction between the superior vena cava ostia and the right atrium. So it takes over as the dominant pacemaker, and it has its own pacemaker potential, which I'll be talking about sometime later. Now, pacemaker potential depends on a small influx of sodium ions. So these sodium ions continuously keep flowing inside, and this influx of cations makes the resting membrane potential go to the threshold potential, and then it triggers the depolarization. Now, unlike other cells, depolarizations are based on sodium channels, but in nodal cells, in conducting cells, the depolarization is based on your calcium channels, right? It's a current of calcium rather than sodium. And we know that autonomic tone modulates it. It can make it faster or slower. And there are these following factors also which can affect the SA node impulse generation: cardiac stretch, temperature, hypoxia, blood pH, thyroxine, serotonin, etc. So they all can influence whether whether you should be tachycardic or bradycardic. Now, this is a rough sketch which I've made on the conductive system. As you see that I'm clearly not artistic, I'm more autistic rather. But the basic what you need to know is that the AV node sits at the junction of the right atrium and the atrioventricular border. So this AV node is mainly helping to conduct the impulse at a slower rate to the ventricles. Now we know that here you have a fibrous band, and this is called the annulus fibrosus. Now this annulus fibrosus, it prevents the impulse coming from the atria going directly down towards the ventricle. But instead, only the AV node can conduct these impulses to the ventricle. So AV node goes to the bundle of His, and through that it divides into the left bundle branch and a right bundle branch. And what I forgot to mention here is that the left bundle branch gives some septal branches, and then it gives a anterior left anterior hemibranch and a left posterior hemibranch, and then finally it divides into those Purkinje fibers which go deep into all the myocardial cells. And this is the sketch. So why do we need to know this? Because in clinical practice, when we are dealing with ECGs, we would be dealing with a lot of bundle branch blocks. So depending on where the block is, whether it is here, or whether is it here or here or here or here, the ECGs will manifest in various ways, which we will be discussing in the due course. But this is the basic idea which you have to have. Now, let's talk a little bit about the action potentials in the heart. Now, there are two types of cells. The first type of cells are the conducting cells, and the second type of cells are the contractile cells, which are the myocardial cells. Now, both are excitable tissues, so they have their own action potential patterns. So we need to know them because there are targets, pharmacological targets, which we use in treating certain diseases. So the nodal cell will have a shape like this. It somewhat similar to a normal nerve conduction. But look at this. The difference is that there is a plateau phase. There is a plateau phase in the contractile cell which allows more calcium to get flown inside to the cell, because we need calcium to our contraction, to aid our contraction, to make it more powerful, which I'll be talking when I'm dealing with the excitation contraction coupling. So just keep in mind that that is the main difference what we have in dealing with action potentials of the contractile cells. Apart from that, look at this. The cell almost always remains in the resting membrane potential, and once it receives an impulse and it gets taken to the threshold potential, then it shoots up. But look at this. This never remains stationary. This continuously always keeps on going to the threshold from the resting membrane potential. Now, that is from this funny current channel, what I explained. So this funny current channel gives these nodal cells the automaticity. So that's how they generate. So sympathetic action and parasympathetic action can influence these funny current channels, which can either make it faster or slower. So SNO triggers the depolarization of atrial muscles. So non-conducting cells maintain a resting membrane potential, and due to a small flow of potassium ions into the cell through inward rectifier channel, once depolarization arrives, voltage-gated fast self-inactivating sodium channels open, and partial repolarization is due to transient outward potassium channels. So what I've been telling is that the SA node, the SA node gives the trigger to propagate the impulses, and when the impulses reach, they open sodium channels. The sodium influx takes the resting membrane potentials to a depolarized state, and once it goes to a depolarized state, then finally, to maintain the plateau phase, it is interaction. It is the interaction between the calcium channels and the potassium channels. That is what happens. And then finally, when the calcium channel ceases to function, it is only the inward rectifier potassium channels which sends the potassium out, and that is how the membrane potential comes back to the resting membrane potential. So the plateau phase is due to the inward calcium channel, which is the L-type channel. This period increases the permeability of sarcolemmal membranes to calcium. Now, this determines the period of this plateau phase determines the strength of the contraction. And this also prevents the early activation of myocytes, which means during the plateau phase, the muscle is absolutely refractory. And like I said, this annulus fibrosus, it prevents the atrial impulses being conducted to ventricles. So that's the basic what I want you to understand. So let's go through the phases of action potential in a contractile cell. Now the first phase, which is the phase 0, it is actually mediated by a voltage gated sodium channel, similar to a nerve and a skeletal muscle. Now, stimulation of beta 1 receptors will increase the slope. Stimulation of beta 1 receptors will increase the slope. And this is the phase which helps to create the QRS complex of the major ventricular myocardium, the major depolarization. What's phase 1? Now, there is an overshoot of depolarization, and to bring it slightly downwards, there is a potassium channel being open and the sodium channels close, and that causes a mild drop before the calcium channels are activated. So that is phase 1. Phase 2 is voltage gated calcium channels open while the voltage gated potassium channels are there. So this current is offset and it maintains a plateau. During this plateau, the main idea is to get as much as possible calcium, so that this calcium is needed for the contraction. So this influx of calcium triggers the release of calcium from smooth endoplasmic reticulum, and this is the part which creates the ST segment of the ECG. So this one creates the QRS, and this creates the ST segment of the ECG. Phase 3 is the repolarization phase. Now here what happens, the calcium channels close, but the potassium channels remain open. So potassium keeps going out and the depolarization comes down. And this is called the repolarization, and it creates the T wave in ECG. It creates the T wave. And then finally we reach the resting membrane potentials, and then what keeps the resting membrane potentials always negative is the sodium potassium ATPases. They shift sodium and potassium out and inside the cell to maintain a more negative resting membrane potentials. So that is the basic of an action potential in a contractile cell. Now let's go to an action potential of a conducting cell. So you see there is a phase 4. So there is no particular phase where the cell is persistently in a resting membrane potential. So there is a spontaneous depolarization at rest as they have automaticity, and this is called the pacemaker potential. Now the inward current from a T-type channel, the inward current from a T-type channel, they differ from the L-type as they open at a more negative membrane potential. Now, the inward sodium current is called the funny current. Like I said, this funny current takes the voltage, the potential of the cell higher to the threshold potential so that the calcium channels can be activated to initiate the depolarization. Remember, here the phase 0 is not a sodium mediated, it is a calcium mediated. Then you have the repolarization. Here you don't have a plateau phase. The moment it reaches the peak, it comes back down, and it is by potassium channels. So what I want to show is that here it is a sympathetic response, and this is a parasympathetic. Now, a sympathetic and parasympathetic response. You see here that it makes the slope more steep and it makes the slope less steep. So depending on that, the rate becomes faster or slower. Next, what we are going to discuss is the excitation contraction coupling. The excitation contraction coupling. Now, what happens here is that you need to know the structure of the muscle. So let's say you have your muscle, a chunk of muscle, and you have a lot of fascicles in it. So if you take one fascicle out, so this is the fascicle. Now if you take one fascicle out, this fascicle has a lot of fibers. If you take one fiber out, now this is a muscle fiber. Now this muscle fiber is actually the cell. It is actually the cell. It is surrounded by a membrane which is called the sarcolemmal membrane, which I'll be talking later. And these muscle fibers have fibrils. And if you take a fibril out, and this is the myofibril. And this myofibril has a lot of filaments. There are thick filaments and thin filaments. The thick filaments are the myosin and the thin filaments are the actin, and all the actin are bound to a particular disc, and this disc is called the Z disc, and it creates a band which is the Z band. So when you see according to their densities, there is an A band which is having the myosin, and there is an I band, and this I band is around the disc. This is the disc. So this I band is the disc and the actin filaments, and it does not have the myosin. So when there is a contraction, the myosin pulls the actin inwards, and what shortens is the I band, and the A band does not shorten. The A band does not shorten, only the I band is what shortens. So this is the basic what you need to understand. So this is the sarcoplasmic reticulum, which is actually the smooth endoplasmic reticulum of a muscle cell that stores a lot of calcium. And we know that the sarcolemmal cisternae, now uh, during the contraction, we need the impulse to propagate to the cells. So what happens is at these zones in the AI band intervals here and the AI band here, this is the area where you would see this structure. This is called the T tubules. Now the action potentials come, and they come along the membrane and they go along the T tubules. And these T tubules, they have dihydropyridine calcium channels. They have dihydropyridine calcium channels. And together with this, there are sarcolemmal cisternae here. This cisternae, there is ryanidine, calcium channels. There's ryanidine calcium channels here in the cisternae. So what happens is when this action potential comes, it activates dihydropyridine calcium channel, which will bind to the ryanidine or stimulate the ryanidine calcium channel, and it stimulates the release of the calcium stored in the sarcoplasmic reticulum to the cytoplasm of the muscle cell, which is the myofibril. So then what happens is that these calcium get available to the thick and thin filaments so that the contraction take place. So let me just show a brief idea that here you see the thick filaments. Now these thick filaments are the myosins. Let me just make it thick. And you see here there is a hinge with a head. There's a hinge with a head. Now, this is called the myosin head. Now, here we have the Z line, which is the disc, and you have the actin fibers like this. Now, what happens is that when you talk about actin, they have certain active sites which bind to the myosin heads, right? These are myosin heads. They have active sites which bind to actin, right? So what happens here is that these are covered by a molecule, and this is called tropomyosin. Now this is called tropomyosin. Now together with this tropomyosin, there are special complexes called the troponin complex. Troponins. Now troponins are of three types. You can remember it as I, T, C. Now troponin I inhibits actin from binding. Troponin T binds to tropomyosin and troponin C binds to calcium. Now when this calcium comes, calcium binds to this troponin in this molecule. It creates a conformational change which moves the tropomyosin and exposes the active sites. Once the active sites are exposed, these myosin attaches. This attachment process does not require any energy, but there are ATP binding sites right here, and these ATP binding sites have ATPase activity. So when the ATP binds, it gives a certain energy where the myosin head will bend, and now this bending will pull the actin towards the myosin, and this is what we call the power stroke. This is what we call the power stroke. Now what you need to understand is that these when it bends, now it needs to relax. Now the most important thing is that the relaxation is a active process which requires ATP to be broken down to ADP plus phosphate. This energy release is what makes it to detach. So that is why we see when a patient dies, he goes into rigor mortis. Now this rigor mortis is due to an inability to relax because we don't have ATP. The same thing happens when we are running. We run fast and we end up with a cramp, and that cramp is due to a sustained contraction because the cell is out of energy, it's out of ATP, and the cell shifts to the Anaerobic way, it produces lactates, and buildup of lactates will cause more hypoxia, and this depletes all the ATPs in the cell, and then that is why, due to the inability to relax, the muscle goes into failure. So that is a cramp. So this is the basis of the excitation contraction coupling. So the excitation which is coming through the action potential, which is converted into a mechanical event. So they are coupled, and that is why it's called an excitation contraction coupling. So this is what is written. This basically tells you what I've explained previously. And so this is what I meant, that the tropomyosin moves to expose the active sites once the calcium binds. And these are the three troponin: troponin I, troponin T, troponin C. So this is basically the power stroke cycle. So this is the contraction cycle, where you see the resting muscle, the troponins covering the active site, and then finally when the calcium comes, it moves the tropomyosin away, the actin myosin binds, and then with ATP present, they do the power stroke, and then finally with the presence of ATP being broken down, it dissociates, and then finally goes back to the same stage, and that cycle keeps on continuing, and that is how the excitation contraction coupling happens. Now let's go to a more important part in this anatomy and physiology lecture, that is the cardiac cycle. Now, what do you mean by the cardiac cycle, and what does this graph show? It might be a lot to digest at once, but let's break it down into components, right? So what you see here is the aortic pressure. That is the pressure recorded in the aorta. This is the pressure recorded in your atria, mostly the right atria. This is the pressure recorded in your left ventricle, This is actually the volume of the left ventricle, and this is the corresponding electrocardiogram, which tells you what is the electrical event which is corresponding to this mechanical event. And this is the phonocardiogram, so that you know what are the sounds you hear at what positions. Let's start. Now, what happens is that we know this is S1 and this is S2. Between S1 and S2 is your systole. Your systole is your ventricular contraction. And between your S2 and the next S1 is your diastole. And diastole is where your ventricles relax. So systole, your ventricles contract. Diastole, your ventricles relax. Now, at the beginning of systole, so what happens here is that it let's start with to for better understanding. I think it's better that we start with this starting with systole. What happens is that during this is the diastole, yeah. So when the diastole is finishing, so what happens in diastole is that your ventricles are filled in your diastole. So at the end, with the last phase where your ventricles are filled, what happens is your atria contracts. Your atria contracts. So your atria contracts towards the latter part of the diastole. And after that, what happens is that your ventricles go into something called a isovolumetric contraction, means keeping the volume same, the muscle fibers start contracting to raise the pressure, right? So what happens if you talk about the ventricular pressures? So the ventricular pressures start to gradually rise. They start rising gradually. When the ventricular pressures come up towards the aortic valve pressures, what happens is the aortic valve opens. Then what happens? There's a rapid contraction, which is not an isovolumetric contraction. It is a ejection phase. It's called the rapid ejection phase. and there all the blood is pushed out to the aorta. So that time the pressures in the ventricle also will rise, the pressures in the aorta also will rise. So that's why you see both of them rise during ejection phase. Then what happens? The blood gets emptied in the left ventricle and the pressures in the left ventricle drops. So likewise, you see the ventricular volume here during the ejection phase. The ventricular volume goes out. When the ventricle volume goes out, the ventricle volume depletes. That shows this. Now what happens in your left ventricle? Now your left ventricle goes into an isovolumic relaxation. So now during this relaxation, nothing comes into the ventricle. There is no change in the ventricular volume. Keeping the same end systolic volume, the ventricle goes into relaxation. So then what happens? The pressures start dropping, the pressures start declining, and the moment the ventricular pressures come below the aortic pressure, the aortic valves close. When the aortic valve close, you hear the S2. So when the aortic valves close, you hear S2. So then the ventricular pressures keep dropping. The ventricular pressures come down, drop, 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 drop. Then what happens is it comes to a point where it drops below the atrial pressures. It drops below the atrial pressures. Then what happens is your mitral valve opens. Your mitral valve opens, and then this is called the rapid inflow, which is also called the rapid passive ventricular filling. The rapid passive ventricular filling. So what happens here is that the ventricle is filled rapidly. So you see a spike in the volume and the pressures still keep dropping. Then after the rapid inflow, there is a period where the pressures are slowly building up and the ventricles are still relaxing, and the pressures in the atria are also slowly being stable. So that is due to a slow influx of blood. So that is called the slow passive ventricular filling. Your atria are connecting to your ventricles like a conduit because the valves are open and the blood is continuously being flown from the pulmonary circuit. So that is called the slow passive ventricular filling. Then what happens after a certain time towards the end of diastole, your atria receive depolarization and they contract and they squirt whatever remaining of blood is there. So that's why you see a small bulge here and a small bulge in the ventricular pressures. Now this is the atrial contraction, and what happens is that when the atrial contraction is over, your diastole is over, and then you start again from isovolumetric contraction, and that is the cardiac cycle. What you need to know is when the mitral valve, tricuspid valve closes, that is when you hear S1. When your aortic pulmonary valves close, that is when you hear S2. Now, what is S3? When there is a rapid passive ventricular filling, the huge load of blood falls down to the enlarged ventricle. This enlarged ventricle will shake due to the rapid influx of blood, and that will cause a sound, and that is called S3. At times, it's normal to be heard in some individuals like athletes, but sometimes that shows that there is hyperdynamic circulation. And then finally, when you have the atrial contraction, and when there's an atrial contraction, a forceful atrial contraction against a very stiffened ventricle due to hypertrophy, due to hypertension, then you hear a S4. S4 is heard very shortly just before the S1. So that we need to know where S4 would come. So S4 would come somewhere here. So S1, S2, S3, and S4. S3 and S4 both are heard during the diastole, and S4 is at the late diastole. And you see the relationship of the QRS complex. After the QRS complex is over, only the mechanical event happens. So always the electrical event happens first, then the mechanical event happens. All right. So next, Next, what we are going to deal is with the cardiac cycle. This is basically what I explained you. So the heart sounds. You have S1 due to closure of mitral and tricuspid, S2 due to closure of atrial and pulmonary. Now, S2, there's a split. I know most of you all won't be hearing it, only the trained ears can hear it. But we need to know that during inspiration, we are meant in a way, it's made in a way where when we are breathing in, the blood should remain a lot in the pulmonary circuit so that it get oxygenated. And when we are breathing out, we don't need the blood to remain in the pulmonary circuit. So the blood remains more in the left side. So that is why during inspiration, the pulmonary component closes late. The pulmonary component closes late. So that is causing a physiological splitting. So this that's called the physiological splitting. Now, these are the types of splitting. So, a widening of the split. Now, when there is a pulmonic stenosis, the blood flow through the pulmonary valve is quite lengthier. And when there's a right bundle branch block, the conduction of the right side gets slower. So, the contraction of the right side is slower. So, it widens the gap. So, the P2 closes late. So, that is an example of splitting. The next, if there is an atrial septal defect, when there's an atrial septal defect, the blood keeps on going to the right side of the heart from the left. So that causes persistently, even if it is inspiration or expiration, the blood flow in your pulmonary circuit is lengthier. So that is why they cause a fixed splitting, and that is very characteristic to diagnose ASDs clinically. Now, what's a paradoxal split? Now, during left bundle branch block, the left side of the heart is discoordinated and they are quite slow and they close late, right? So, in expiration, what happens is in expiration, already the blood flow in the left is prolonged, so it becomes even late. So that is the paradoxal splitting. But we need to remember that's not that important in terms of your examination, but fixed splitting, physiological splitting, yes, they will be questioning you on that. The last in this section is your JVP. It is a very important tool in your clinical examination to find out the fluid status, to find out the cardiac function. So your JVP consists of few waves, the ACXVY. ACXVY. A is due to the atrial contraction. Remember, A for atria, A for atria. So what happens? When your atrias contract, now JVP is actually the projection of pressures from the right atrium. So when your atrias contract, there is a backflow of pressure which goes up towards your neck, and that is seen as an A wave. Then what happens when your atrias contract? Now your ventricles go into isovolumetric contraction, the pressures build up, and then when the pressures come towards the pressures of the atria, your mitral and tricuspid valve closes. So due to that isovolumetric contraction, C for contraction, this tricuspid valve closes, and this close will cause a small jet of blood going upwards, and that is the C. So A for atria, C for the contraction. Then what happens when the valves close? The atrias are actually empty. So the atria's pressures will drop, right? The atria's pressures are dropping. So this drop is called the X descent. This drop is called the X descent. Then what happens? The blood keeps on filling the atria. When during the atrial filling, the blood keeps on filling, and that is the rise in pressures in V. Then what happens is that during the ventricular contraction, after that happens, once the atrias are filled, the atrias have to empty to the ventricle. The atrias have to empty to the ventricle. So when the mitral valve and the tricuspid valve opens, This drop of pressure due to the emptying of the atria is your Y descent. So ACXVY, that is the normal JVP. Now during atrial fibrillation, you will not have atrial contraction. So you will have absent A waves. You will have absent A waves. What happens in tricuspid regurgitation? When you have a left ventricle contraction, where the ventricles contract left and right, the pressures are directed upwards because the tricuspid valves are regurgitating, and that is why you see a large wave, and then you don't see a proper C, because that C is made from a small bulging of the valve causing the upward flow of blood, right? So you don't see that in tricuspid regurgitation. Instead you see something called a CV wave, a large CV wave. So you see one small hump and a large hump, one small hump and a large hump, that is very clearly visible in a patient with tricuspid regurgitation, CV wave. Then tricuspid stenosis. In tricuspid stenosis, what happens? Your A wave becomes so peaked. There are peaked tented A waves. Why? Your tricuspid valves are stenotic, and when the atria are contracting, the pressures going back is so high because it has to squeeze through the stenotic area. So that is tricuspid stenosis. So you will be questioned on these things in your true false, and sometimes in your SBS also, and that's the basic of JVP. And this is what I mentioned before, and that's the end of session 1, the section 1, which is the relevant anatomy and physiology. Next we'll talk about stable angina, which is a part of ischemic heart disease, and we'll continue with there onwards.